Rajgaon runs into the Bala River, which then runs into the Sitalakia, which goes through Narayanganj. People actually have been moving away from the banks of the Begum-Barik Pal. It is so bad, not only can you not use the water for drinking, not only can you not swim in it, not only can you not fish in it, you can't actually live near it. People have been leaving the banks, that's how bad it is. And they're leaving it for health reasons, I think, primarily. And also because it's just unbearable to live there. So, I could have done more on that, but never mind. Why are things not happening? Well, from my perspective, there were two areas that I really emphasized. And they both contribute to improving the surface water quality, because if we don't do something about surface water quality, we're going to have huge problems supplying drinking water. We can't go on mining the groundwater, and we can't use the surface water a lot of the time because it's just not usable. You can't run it through a normal treatment plant. You have to run it first through a sewage treatment plant, and then you run it through a normal treatment plant. That's not a logical way of going on. And in some cases, for example, the chromium from Hazaribagh won't come out whatever treatment you use, unless you use a very special treatment. It should not be being treated after it's got in the river. It should be being treated first. So why is this not happening? Well, I agree with Dr. Khairul about the traditional approach to sewage treatment could be improved by recycling the waste and so on, but still I think we need that. Why haven't these plants been built? Why have we only got one plant which from time to time breaks down and doesn't operate, the one at Saidabad? And there are actually, I think, at least 5 sites earmarked. I worked on one of those sites in 1975. It's been there for years and years, the Wasa site at Demra. The money's available from international lending organisations. The designs have been completed by Wasa. I think maybe some of the work is being done now, but the major delaying factor, according to my colleague in Wasa, was simply getting the development project pro forma approved, and that was a very long and elaborate process. So simply delays in the system are a major factor in not developing the infrastructure. And we all know that infrastructure development is a major problem in many different fields. So I think that's one area, and I think it would be possible to improve that. The second one relates to the industrial pollution. Now, many of these industrial units have pollution treatment works installed, but they don't use them. And they don't use them because they cost money to run. And there's a major problem with inspection. And as I think Dr. Khairul pointed out, the inspectors are almost powerless because the manufacturers are extremely powerful in many different ways, in financial and political ways. And I've actually been at a meeting with the Ministry of the Environment, a symposium like this, in which the Ministry of the Environment was asked, why don't you do something about that? And they said, well, we've tried. If you have any ideas, please help us, because we're trying, but it's extremely difficult. And I think the pressure on the other side is very strong. I even suggested to a friend at Buet Engineering University in the water research unit, who's a professor of water chemistry, I said, look, let's set up a little monitoring unit. We get some international, we get some money for this, and we won't do anything. All we'll do is monitor the water quality and publish it in the Daily Star and Proton Allo every day, and we'll just say where the station is, so it's obvious where the stuff is coming from. And his response was, are you trying to get me killed? I thought you were my friend. So there are some pretty fundamental problems here, and the problems contributing to the industrial pollution are exactly the same problems which led to the Rana Plaza collapse and 1,000 people dying, and probably and sadly will lead to more collapses and more people dying, and they're because the regulations are not being enforced, and it is extremely difficult to do that in the face of the powerful interests which are trying to stop them from being enforced. And I think absolutely it comes down to political will, and that's why I do propose to move the Jatra Shongshat to the Namabari. And I am prepared to compromise on my proposal. If they can't go permanently, they should at least meet there for 1 week in April, right, when it's hot and the water level is low, and they can have direct experience of the problem.
Thank you, my group, for this proposal and your quick and ready response. Now, Mr. K.M. Nurullah.
Thank you very much. I think most of the questions have been addressed, but I like to respond the question of my senior Mr. Nath. He like to know from me that what are the activities, what are the actions that civil society and the government are taking for integration of waste and segregation of waste at the door. Yes, there were a lot of advocacies so far for long years. NGO, I mentioned very shortly that NGO and civil society before even government and donors, they selected some areas, they made some pilot projects in some areas so that people can get habituated to separate, segregate waste at the sources. But they could not come successfully as yet. It does not mean that we should abandon it. We must try again and again so that people can get convinced. And the most important thing is that the law implementer, the civil society, NGO, donor, nobody can do anything if people who generate waste cannot come forward to address their own problems. In everywhere, in every country, developed countries or developing countries who are taking these issues seriously, they participated. The people participate because from the door, from the home, from the shops, from the industry, from the medical center, they segregate it by rule and by law. There are some compulsion on it because the people who used to collect the waste from the door, they do not receive the waste if it is not separated. So there is one compulsion, one regulation that the government can impose. So it will take time, but I am optimistic that time will come when people will realize that it is their responsibility to segregate waste at the source, and it is their responsibility to help the city corporation or municipality to take the waste in segregated manner and can dispose it hygienically and scientifically. Then comes about medical waste. Yes, there are a lot of improvements have been done in the medical side. Medical waste management manual is there. Drug Center, Drug University were involved in framing of this medical waste. I had a little opportunity to share my experiences with this. So it is there. But question is that whether it is implemented or not. That is the responsibility of the people. For the people of the society, for the people of city, for people of the municipalities. But I will come that they will realize it. Again, about disposal of waste, Prism is there. Prism has introduced one kind of vehicle that they take waste from the medical centers and they dispose it, I think, from in the incinerator or somewhere else. But this system is not. But they cannot cover the whole area of medical waste in Dhaka or in other areas of Bangladesh. But we are coming up. We are addressing the problems. We are addressing the problems. Time will come when we will make sure that these problems should be addressed. Thank you.
Thank you, Mr. K.M. Nurullah, for your response. Now, Mr. Khairul Islam, he likes to make a 2 minutes.
Just 2 minutes. I mean, because I had a feeling that we are concluding this session with a kind of frustrating or pessimistic mood. No, things also are happening which are in positive direction. For the last 3 years, we have been collaborating with an Indian Center for Science and Environment. First we sent participants, but then the faculty came and trained in last 3 years over 200 architects, engineers, planners, and academics. As a result of that, now in Kuwait, in Shah Jalal Technical University, and in all these places, we have rainwater harvesting plant installed as demonstration plot. All the curriculum, yesterday, the Kuwait was the last one, and yesterday they actually adopted it. It's in the curriculum of the civil engineers, and Bragg University was the pioneer, the civil engineering department. So now those who have trained have started installing rainwater harvesting and recharging and reuse into factory plants, into households, and it's already got into incorporated in the National Building Code, and Rajuk is also trying to issue a separate circular for the Dhaka city's construction code, but still they are negotiating with rehab and all this. Hopefully it will be done. So with all this effort, we are hoping in next 3 to 5 years' time, our engineers, architects, planners, all the buildings, anything over 2,000 square feet surface area will have rainwater recharge. So the kind of scenarios we are seeing, 3 meters decline per year of groundwater, probably it will be checked. Maybe it will take another 5-7 years, but we hope it will be checked. The other thing is wastewater disposal, and at the same time, all these universities are now in their academic curriculum has incorporated, because we didn't have those simple technical know-how. If you ask one of the civil engineers or planners how to do it, now you will see if you go to Grameen Phone's headquarters, they are reusing the wastewater into their building. If you go by the Gulshan Avenue, all the new buildings are coming, they are saying we are using green technology and all these things. So if we can have critical mass of national resources that we have tried to do, it starts coming up. And also, I think Liaquat gave you the data prior to the Saidabad phase 2. So now, with the Saidabad phase 2, now the surface water use is over 78%, so ratio has changed. And they have got a plan to make it 50-50, 50% groundwater and 50%. It requires huge investment. Like this next plan which is coming up from river from Meghna, that would require $620 million of investment. And if government does it for the Dhaka city because it's political hotspot, then all the people living in the Chor, Coastal Belt, Howrah, they get deprived of their due share. So there is a tension between where to invest and who gets priority. Obviously Dhaka gets priority. So the overall scenario is in the urban side, from where the powerful MPs are coming, you will see something is getting changed. But overall the scenario, a bit frustrating, but there are positive signs as well. Thank you.
Thank you, Mr. Khairul Islam, for the last response. Because we are not in frustration, we are raising our voice. Yes. This means we are raising our voice. That means hope grows our voice. So we have amended the environmental law. We are trying to strengthen the environment department, and Mr. Khairul Islam has projected that we are taking initiatives in different fields. So time has come up, and that is we are developing the foundation. And a situation will come soon that we will the situation will improve, because we have now no other alternative. It is now difficult for this world landmass to feed 6 billion population, but it will go to 9 billion by 2050. Our population, our projection shows that it will go up to more than 20 crore or 200 million, and this landmass will feed them. So we have no other efficiency to become water efficient. We have no other alternative to become waste management efficient, because our waste is more healthier, because 80% of our municipal waste is organic matter, and as it is organic matter, it can be converted to energy as well as to fertilizer, and we need this fertilizer because to sustain this our lives and to sustain the environment, because and in this world or in everywhere, there is a balance. There needs a balance between 3 kinds of lives. One is producer, one is reducer, one is consumer. Producer means plants, always they produce. And the consumer, that is human being, animals and the birds, they always consume. And the reducer, that is microorganisms, they convert the that is organic matters to inorganic matters. And because the plant cannot take organic matter directly, they take inorganic matter. So the balance is needed. And for this balance, we need more that is organic matter, and this organic matter will be converted to inorganic matter, otherwise plant cannot take it. So a balance is needed, and for this balance, we have to be more water efficient, we have to be more waste management efficient. Thank you, ladies and gentlemen, for your contribution. Thank you, the resource panel members and resource persons, and for your presentation, and for everybody's participation to make this session interactive, more informative and attractive. Thank you, lecturer.
একটা নাম উচ্চারণ করি না আমরা বাইরে থেকে
পৌঁছাতে পারেনি ওনারা শুধু
ও আচ্ছা
গ্রামেই বসে থাকে
এটা ঠিক কিন্তু তো গ্রামে
ওরা তো গ্রাস রুটের মানুষ ওনারা তো ওইদিকে তাকায় না আর তিনাদেরও চোখে পড়ে না গ্রাস রুট বুঝছেন না
better. So, how we can start from Roman. You know, if the private sector working for health sectors with good name and face, because government alone have no the capacity to do for everybody's in this country. So government is doing one side and private sector is doing the other side, especially in the poor marginalized, among the poor marginalized people, slum areas or other remote areas, NGO or private partnership is very much famous in our context. So we cannot with them. We are very much we are not potential to carry out our duties in the health sectors. So what we are from the various sectors. Questions, but before that, I will ask my panel member to say little 1 minute or 2 minutes regarding their activities, their organizations, and how they are working there, and what they are feeling, and what their responsibilities and commitment with these activities. Thank you.
They also had some sort of government set up desire, I should say, cannot term it in a better way, that it is not uniform in throughout the country. Somewhere it is better, somewhere it is not that good, somewhere it is very bad. So, and there lies the question of, say, where the locality is, whether it is hard to reach, whether it is a urban setup, whether it is, say, or all these sorts of things. So we do have several challenges, but government is taking, I think, a good sort of activity, as there are a lot of
core business without the fund of the donors, our core business. But that is marketing, socially things. That is, you know, we are family planning based organization, but we have gone through many other issues of health related or important, those who are important at this very moment. But the thing is that we have started in 1974 with, you know, the senior people all know Raja, Maya and all these were there at the very first time. And then came the oral saline, which is the star product and which is the household name. And even when I tell somebody that I am with SMC, what SMC, I mean, do you know saline? Okay, oral saline, fine. So that is the catch of SMC, that their products are now household items, and they can get some sort of to have a sustainability with their total marketing and sales network. So that is one interesting thing. I think if I just start on that point, it will take, I think, the whole time of this session. So, and then we just into areas of say importance, that is we are very clear about our agenda that government is doing and what the tertiary care level or the secondary care level or primary care level we are fitting and fit ourselves. So we thought that we can fit ourselves in primary level and especially we can look at awareness raising sort of thing. If people are aware, then they can go for so many places for their what they actually want. And you know, and as sir told that I am looking after BCC, so I may be a bit just inclined related activity. Now, as we have to talk about private sector engagement. So just let me give two examples of SMC got private sector on board. One is our Blue Star network, which is a network of private service providers at urban or semi-urban level. Even in some cases rural level, they are having a pharmacy. They used to sell drugs. They were not graduate doctors, having some sort of training with some institute, or they are having this medicine business from their father there. And as you know, family was at that point actually injectables and other methods. It is not, I'm not injectable patient. Government was providing. So with the collaboration with government and USAID, we have started a program. And of course, engineering health was there with the training part of the providers. And you know, all the providers, those who are not medical doctors, they are providing injections and others. You know, all the pharmacy, those who are practicing in the pharmacy, even I have seen in Sylhet, I saw once, he is giving IVs in chamber. There, going there, and it is not been monitored or something. How? So we were thinking that why don't we put a platform where government monitoring, the training, proper training will be there, and we will get service out of the government. So then we have the training protocol developed. We have submitted it to the DGFP, and we got the permission, and with the help of the training team of Engineer Health, we have trained all these several providers, many providers. Now the number is 4,000. So they are providing injectables as Somagen. Another catch of privatization, that is that we are not just looking at depot models. So then we can demand creation can be more stronger. And maybe just 1 minute. I'm talking about another higher sort of activity with the service providers, that is long-acting methods, long-acting methods are only in our level in sector. Now we are trying to get the graduate doctors, FCPS and others, gynecologists and others. So we are training them to insert IUD at their chambers. So here is another private sector. In the area that only government was working, so there could not be. Just one important thing I mention. Say long-acting were in government sector, it was attacked with Lungi and other things, and people thought it was a poor man's service, poor man's say method. So it was class people or middle class, they were not much interested to go over there. And it was said they have to buy from the graduate, so they have to buy it now. They can go over there, and that might getting, I think, to some extent. We are in a very preliminary stage, and I'm supposed to talk about it. Let's see how it goes. But book is a total success. It is rolling fine. And if you like to know more about it, I think well, I can just share you about our other programs. So thank you very much.
Thank you, Dr. Zahidur Rahman. Something about the activities of the NGOs and also and Dr. Zahidur Rahman. I think you will ask that session. So I will invite Dr. Seth.
Good morning and assalamu alaikum to everyone. I'd like to start my talk with three areas, which is I'm not a health person, I'm not an urban specialist, neither do I work with private sector. I'm a poverty economist and I work with the World Bank, and we work with the public sector. With those caveats, I'd like to share with you what we've done. We think basically manage the social sector is really to think about best. Now, recent poverty analysis that we did, what we found is that even though we've had remarkable reduction in poverty in and urban areas, we still have a very large number of poor people in urban areas. So the figures right now, rural poverty is 5%, which is higher than the national average, 30%, and urban poverty is actually much lower at 20%. And if you look at extreme poverty in urban areas, it's at a remarkable single 8%. So these are remarkable statistics for Bangladesh. But of course, given the population of Bangladesh, 10 million people in Bangladesh are still living in poverty in urban areas. But then when we look at the coverage of social protection in Bangladesh, what we find is that 95% of safety in rural areas. So there's very little coverage of social protection. Learn more about why that is the case. What are the challenges of this statistic? The World Bank 2 years ago, we started a pilot project in because there's a large number of urban settlements in Narayan. And so what we want to do is exactly what are the mechanisms through which perhaps one can provide incentives in urban slum areas to improve the socio-economic conditions of the slum dwellers. We look at ways education situation of children in slums as well as nutrition, just because, as you know, that nutrition is a huge problem, not just in areas but in poor areas. What I want to do is share some of the findings that we've had. They're quite surprising in terms of what we found. We put together we have resources, we had great political commitment, local had a dynamic mayor of Narayanganj supporting our project. We there were constraints to be involved in the farms to provide the supply side, which meant allowing the mothers to bring their for regular growth monitoring, which was a condition for them to receive a cash transfer. We put for mothers. We put to state-of-the-art payment mechanisms to the post office to provide electronic cash cards to each that they any time to the post office and withdraw money at any point. So we thought through every single detail, and we put together this pilot. We've just finished evaluation at the end of the pilot, and we 40% attrition rate. So 40% of our original population are no longer there. For us to understand what happened. incredible finding. So, really possible. The best social protection urban environments. And so that led to some and that was why this is a because we thought in a year's time we would not have to manage our beneficiaries and actually see the impact. And so I think what we did in the past were your marginal the worst affected. As you know, in they are very sort of mixed population of people who are critical for slum that is very well protected government. So the mayor is very supportive of the there is no threat for eviction. So this was really the opener for us. All of what we wanted, we could still not on to a large number. I think the question that there is of housing that at the bottom people have to give them a permanent loan which would allow them to invest in physical capital. I think the role sector and it's one facet problem. I think it's all the right housing, environment issues, there's right of like services, property. So these are all things we want to see a complex model for support to urban poor. And this is not a public initiative, it was have to happen through public-private initiative. I'm happy to talk more about the process, but I think time is up here.
We know day by day, at 3 to 4% people are adding to the urban population. So, and we know that everybody should that the people coming from the road, they are coming from the population and and not go against they are in the of the city are wholly responsible for I try to others and more than this. Thank you.
If I said specialist, but social we several of the business that tackle the same in a manner and that you pay on and there. Taking out private business we as a investor can invest over time that investment is not on that. So any profit that is plowed back into the business center will be in 2006 to idea to have
entirely by trying to solve social problems, where the aim is not profit maximization for the investor. And we have created a series of social businesses both in Bangladesh and abroad. And I'll just touch on a couple of examples in Bangladesh. One is a partnership with Danone, which is a French company that knows that Ramin and Danone both invested to create a yogurt company. Basically, the yogurt contains Shakti Doi, it's a Bogra that produces a yogurt that contains micronutrients that are lacking in the diet of the children who live in that area. The idea of this is that if the child takes 2 to 3 cups of this yogurt every week, he will cover the nutritional deficit in his diet, and at the end of 1 year, there's be a significant improvement in his health. So the purpose of this business is to improve the health of children. You run it as a business, so you can recoup the money and reach more and more people with it. And Johns Hopkins actually did a preliminary study on the impact of Ramin Danone and found that at the end of 1 year, a group of kids, 6 to 9, were taking this yogurt compared to a control group of kids who were taking a non-fortified yogurt. They were performing better in cognitive tests in terms of height also and in terms of mid-arm circumference. So at the end of 1 year, you saw that there was a significant impact. So this is one example of a partnership with a big private sector company where they bring in their expertise, and Ramin brought its reach into the villages, its expertise of the local population to bring in an intervention that had a good health impact. Similarly, we have another partnership with BASF of Germany, and they have a proprietary technology which is the insecticidal, long-lasting insecticidal mosquito net that is being distributed globally as one effective way of tackling malaria. And they invested in this social business with us. They've also committed never to take out any profits beyond what they initially invested. And they taught Ramin and Bangladesh how to produce these nets with the long-lasting effectiveness against mosquitoes. Basically, it's a mosquito net that repels mosquitoes and will kill a mosquito if you get a light on it. And even after 25 washes is still effective. So we are producing it here, and that's also being marketed through the network of villages as a way to fight insect-borne disease. So these are 2 examples of partnering with private sector companies where they bring in knowledge, know-how, technology, and it's deployed to help solve a social problem. Neither of those 2 companies, by agreement, will take out any profits from this. So we've created a series of such companies in Bangladesh and now around the world. And increasingly, we're involving Bangladeshi businesses into this process. We hold something called the Social Business Design Lab once a month at Unicenter. And the idea is to bring entrepreneurs, businesses who are interested in getting involved in social business, and to help them find the right partners, whether it's investors or entrepreneurs or people with marketing expertise, to create social businesses. We've created, since the start of this year, we've had 9 design labs, and we have already 10 social businesses that are running. One of them is with Softy. It's a company that produces low-cost sanitary towels for garments workers at 3 takas. Again, neither Ramin nor Softy are interested in taking money. The idea is to provide sanitary towels for the hygiene of garment workers in Bangladesh. So this is a little bit about social business. If you have more questions, I'll be happy to respond. Thank you.
Now?
Just I want to say, I was in the Gramin Health Program for some time. I think Gramin has done an excellent job with the rural people. As we are talking about urban soil, you mentioned it earlier. And I'm just feeling to say,
just the business company and other things, whatever I say is non-profitable or profitable. So now I am inviting Dr. Sanjida Hassan to tell about her and her organizations.
At one time we are named APSC, so that time actually Engineered Health worked mainly with the sterilization, female and male sterilization. Then in the course of time we have changed our name as well as our vision. So we now working with the family planning, clinical family planning, and as well as the expert of maternal health like postpartum hemorrhage prevention, fistula prevention, this kind of work. As I mentioned that till now actually we are mainly work strengthening the capacity of DGFP, Director General Family Planning, for clinical family planning, that long-acting irreversible contraception and permanent method. And as Dr. Jahid already mentioned, that you know, in Bangladesh recently, very recently, in 2011, BDHS shows that the private sector shares in family planning, especially in the short-acting family planning, is 28%. That is enormous because even 20 years back when they started working with the short-acting method, then it was actually only government sector who worked for the family planning. But for the long-acting method, long-acting reversible contraception and permanent method, actually till now, private sector was, very dormant because only but some that kind of female sterilization, the other services are not provided from the private sector providers or private sector facilities. The main reason was the commodities that need for that the IUD and implant, the two long-acting methods that were not available in the private sector. Solely DGFP, the Minister of Health and Family Welfare Director General, who is responsible for providing the family planning service, they are the solely. I mean, they can only distribute or provide these services and this method to the to others. And only few NGOs actually, the affiliated NGOs from DGFP, who can provide these services. Recently, for 2 years maybe. That also mentioned Dr. Jahid that before 2 years, with the concurrence of the Director General Family Planning, Engender Health, in collaboration with the social marketing company, and a project called SHOPS, and of course with the largest, professional bodies in Bangladesh for this arena, OTSP, started working with that that provide that long-acting reversible contraception and permanent method in the private sector, for profit private sector. And USAID come in front and they actually donated some IUD and implant. That's I mentioned the two long-acting methods which should be available in the private sector to the SMC, and SMC overbranded the method. Then they provide to the provider with a that is very overbranded and with a very minimum MRP. That actually doesn't cover the cost. The reason for providing, the putting the MRP is just for to make them habituated with provide some money to take the services. I want to mention that in the government sector, no client or no woman that pay for their family planning services, not even for permanent method or other clinical methods. Eventually, they actually get some compensation for transport and wage loss and food rather than they pay something. But here in the private sector, where we are providing these commodities to the private providers, doctors mainly, they actually need to pay for the services like other services they pay to the doctors. And Engender Health actually now develop the capacity of the private sector. Till now, we developed the capacity of almost 300 providers in large hospitals like private medical colleges, and also the providers who actually provide services in their private chamber. These providers are gynae specialists, obstetricians, and also the normal MBBS doctor. We hope that with the public-private partnership, we can expand long-acting reversible contraception and permanent method in a total marketing approach in Bangladesh in the near future. Thank you for hearing me.
Thank you, Dr. Sanjida. Now we have already curtailed 2 minutes from the audience, so sorry. I think this is time for question answers, and after that, as Dikata sir is here, I will give 2 to 3 minutes him for conclusion and also. So now the session open for question and answer.
How this will be pursued, how this will be implemented. Thank you.
Thank you. As I know, here this is the session for question, answer and recommendation. So we can say in 3 ways.
Sorry. Can everybody hear me? I'm making all the noise myself. I've been thinking the whole day to ask a clever question, and I can't come up with a clever question, so I ask a stupid question. I've been walking through the slums, and it seems to me that in those slums, actually the health industry is rather big. Every 5th ramshackle shop is a pharmacy. You know, where drugs are sold under the blazing sun, under, you know, there's no, I'm coming to that later. I also know, I'm coming to the quality and the equity of that. I also know that actually in Bangladesh, health is privately financed for 64%.
Yes.
That 64% is basically paid for not by the poorest. That 64% is coming, if I'm right, I got my figures right, from the highest 2 quintiles, 3 quintiles. So we have a whole portion of the population who actually doesn't have access in urban areas, because in urban areas, like I said, you know, it's the health industry, the private industry which is delivering health services. Now we talk about partnerships, and I think we should a very wide scope on partnerships. It's not only kind of what we hear here is entrepreneurial initiatives, but it could come from the other side as well, where government is contracting out. It could be memorandums of understandings to deliver complementary services, etc., etc. But key words in this is quality and equity. And for me, from a public health point of view, is how do we ensure this? How do we harness the already large private sector health industry, which is there in even the poorest areas? You know, I mean, in the slums. Thank you. Maybe some ideas on, you know, because
thank you. Anybody can respond? Like to respond?
I want to add something.
My
question is, I sent a sleep. My question is, everybody is saying about the marketing, SMC and ramming. I want to stop marketing, especially for smoking and some other things. I don't know how we can achieve this to stop the marketing of smoking and open smoking protection. I don't know who is responsible to protect it. Of course, it is same thing, addiction. In my mobile clinic, I used to attend, and I have a public addressing system there. I welcome people for give up the smoking habit, but response is very poor. Exception is there. A lot of people smoke, give up their smoking, but maximum people don't agree with it. In front of my hospital, a lot of people is selling cigarettes and they are smoking. I know as a professor of law, I also teach in law department. Law is there, but nobody is accepting all these things. I met with the Home Minister, Health Minister. I provide a lot of application. Who is responsible? But nobody is taking. I don't know this urban health, how they will fight against this. This is a challenge. This is an anti-marketing, and my mother died with the chewing of tobacco leaves, cancer. That's why I am very much more concerned for the female also. We are now taking all these things. I hope everybody understood. And sometimes now I am providing this mobile clinic for journalists also, press club. Every week they attend the press club, and more than 20 spots in Dhaka and Tongi. Every day it attends, 65 days, even 2 days.
Thank you, Professor Lawrence. Corner, those who are very much to aggravate or to promote the smoking. So our government, as I know, even for breastfeeding, it is such a good thing. But we make some code again for breastfeeding that it cannot be marketing. It could not, so should not be coming to media, the artificial feeding. But Professor Taluk is becoming failing and failing. So how can I make joint hand and can fight against the bad thing?
Let me add one point. I asked some of the magistrates why you are not charging fine for smokers, especially who smokes in the open as well as in bars and other. They say they have no any receipt book with them, and police also say like that. So media is there, and every day we say you have to find something. This is a very dangerous. We are not free of this hazard. This is a big hazard, I should say.
It's a good recommendation. I think it should come up with the recommendations.
So last 5 years, I am saying all these things, but it is in paper.
Please.
Nobody is writing. Thank you very much. If something happens,
please stop the.
Okay.
Some as well as well-to-do families. So my question is, when you find 40% attrition rate is pretty high despite giving all these facilities, did you try to follow up, like what would be their incentive or preference for a settlement of housing? Because what my experience working with 20 years in slums in the areas, that the rural people, those who migrate to the urban areas, they try to create an environment, a rural environment in urban area. They continue practicing that. This is how there's a disparity in lifestyle between urban settler and the migrant from rural area who settle here later. This is how the slums are being built. It's not that the slum could not be built better. Just because of our rural practice, they just promote the area. So I know a group of architects, engineers, civil engineers, they have been thinking of this modeling to have a sleeping station for the migrant people, poor people, so that people work outside and they come and sleep at a low cost, like 2 taka, 5 taka, something like that. So I'm just curious to know that those are the perspective of the researchers, perspective of the program planners. Did you into your model, what is the requirement or of those people for whom you're trying to develop this model? This is a question. At the same time, this is important for people like us, researchers. We do a lot of innovation, a lot of invention. We are looking at the perspective of the recipients. We think we're the best people. We know the problem. We just throw our ideas. That is happening all the time. And we criticize ICT why you cannot translate research into policy so fast. Question. Can I go to the second one? The time project. Lamia Morshed, you actually shared fantastic information. The Shokti Doi has been a criticism from researcher side, who are also in the area. One of the criticisms was that the cost of Shokti Doi is pretty high, 15 taka per cup, right?
Not in the villages.
Okay, so there's a disparity in urban areas and commercial. So that is the price kept to the product. And your target is for people, and I'm very happy to know that Johns Hopkins did the research and find out that it was statistically significant as a nutrisalary. When it was developed, it's very very costly, and then it was brought down to 3 taka now in the open market. Everybody can afford 6 taka probably now, I forgot. So if everybody can afford, when they know the information, they pick it up. But this is important, I think your work, and for us also to know who would be the target. Shokti Doi is available each and every departmental store, of course high-end departmental store, not poor shops. So that's not even the Mudi Dokan.
No,
so that is my question.
Basically, there are 2 products. There's a product in the village and there's a product in the city.
So that's the question you made, yeah.
And so the product, because of the rising price of input, especially milk, in order to keep the price of the product in the village down, it was produced in the cities as a way to cross-subsidize the cost in the village. So the focus of the business is to expand as much as possible among undernourished children in villages. But the way to do that is to sell the product at a higher rate here. Basically, the money that's made on the urban product is passed on to the village, the people in the village. It's not taken out by the business itself. And it's been a way to cope with, especially in the 2 years after the company was started, the price of globally, I mean, Bangladesh went up very high. And basically what you said went outside the reach of the Dhaka group in the villages in Bogra surrounding. So they were able to bring down the price affordable.
Slums. Children in urban slums. I'm worried about this group of people that they I mean, this is explosive information for you all guys. Because I just did a nutrition survey in the 7 City Corporation in Bangladesh, just finished it. So in the high end of the society, obesity is emerging out of 10 children, every 14 children that are higher overweight. But in the first section,
instead of something else. So in the urban areas, the only reach is through the school feeding programs, not in the slums. We don't have the program in the slums, but I think it's something that, it's something that the social business consider. At the moment, very much the focus is on selling the lower end product in the areas surrounding the factory in Bogra, which is in villages.
I think there is one question to you. You answered, and there is already the.
There was a question on health equity. Earlier. The fascinating thing that we're finding from the system is that use of pharmacists as an alternate to doctor services is extremely high. So the reason why you're seeing a pharmacist every other corner is not only are they selling drugs, but that's the poor person's doctor. So that's one. And what you're also finding is that exactly. And then the other thing that we also find is that if you look at the proportion of expenditure, health expenditure is the highest. There is definitely a question of equity, and I think we're not there with the answers. Unfortunately, I think questions of what kind of health insurance for catastrophic illnesses must be thought through, whether perhaps cash transfers to help smaller health expenditures. I mean, those kind of. I think the question, the rationale for social protection in urban areas are quite different from rural, and we are still struggling to understand what is it that we need, how do we devise it. Going back to your question about how we thought we had which is quite optimal for urban slum population to have a mayor's support. The question of preference did not arise, but obviously now we're going back to the drawing board to think through what would be the issues for us to think about as perhaps a second round of intervention. So this is sort of learning by doing. Thank you.
Thank you. I'm Dr. Parveen Fatima, General Secretary of GSB. Thank you for giving me the time. And really, I'm very interested for this session because of the private sector. So I thought it to be public-private associations like that. And who is in the government or this wide I can understand after the main point is the health, definitely. Point, everybody has spoke about the outcome of health, in whichever way they have come out. Her thinking was that, and the last also the household thinking must be, and for improving the health of the urban, peri-urban areas is good. We as a society is also working because of the title. I'm just asking. Society is giving training to all CSBA that has been not because practice some of the things. So we have already trained 1,000 CSBA in the country. We to say the SNC people also that youngsters were also given training through us. So we are also doing a lot of work, but we never expose ourselves as a collaborator with scientists. Is there any for our work included it as a private sector But we are doing with the government also, no? So actually the public-private partnership. Okay? This time, it would have been like better.
So what I know and I understand, there is a public sector, there is a private sector, there is a public-private partnership. We have three things, but maybe on one
for the public.
Private sector.
Working in the health area, but for a long time. We have seen that the private sector and the non-governmental organizations, they are generating advocacy program very much. Even they are continuing in health, education, and the personal hygiene. Major intervention they have made and in fact made them the health consciousness. This is the say social marketing company or others, those who are also working. Indirectly, they have done these things. Say the breastfeeding program, which are working. Say hand washing program, ORS program. These things have been popularized not by the government but by the non-governmental organization very much. And this is one of the major contribution that personal hygiene has been developed due to the private sector intervention, geo-NGO collaboration. One thing we must remember, government sector should not think private sector is their competitor. They are complementary. Exactly. The health role is for the health sector, but others are also. Health sector is not the health ministry. It is a multi-dimensional sector. And multi
LGRD and others.
So, how to encourage the issue is how to encourage the private sector more involvement. This is one of the major issues. Yeah. And one of the critical issue, everybody is saying that the private sector cost of service delivery or management cost is higher in comparison to the government. There are scopes, yes, there are scopes because private sector involves very expert and they are paying higher salary to their incumbent and their service delivery is higher. But there are scopes to reduce it. So one of our recommendations should be that the private sector should try so that the difference between the service delivery government and the should not be too much high. And number two, the government sector in no way should but the geo collaboration in the urban health or in the as a whole, not in the rural areas and are not very vibrant. In the urban areas and those are working very much. Even in the Dhaka city, even in the solid waste management, medical waste management, these are the environmental health issue. You will find Audifon, then Prizone. These people are actually collecting the solid waste in the house to house. This is not the government work. This is not the city corporation worker. And they have made a contract with them that the Audifon or Prizone, they will give their worker along with some relative workers, say women workers, and these are the many areas. There are vast areas where the government has the opportunity to utilize the services of the private sector. And as a regulatory body, the government or the health ministry or the local government ministry or the city corporation and the municipality think, as you have seen the voice of Ivy, she has identified the critical issues, what are the problems in her area. Similarly, they are the politician, they know where the shoe pinches. So I think that this recommendation to the urban health, it should be that the NGO, private sector, they should be more involved. If we mean the healthcare delivery system to take care door to door, because in the urban area, community approach is much less than in the rural area. Rural area peers to community approach, ward commissioner are more vibrant than the urban area. So this is one of my recommendations that the private sector, geo-NGO collaboration should be much more to provide the healthcare delivery system in terms of the health hygiene, health education, motivation, advocacy. Thank you.
Thank you, sir. We are at the end of the session. So I think one question somebody would like to ask, do you like to ask? Because I like to finish. When I am that side, we do not agree to have more time.
This was a project that we did both in an urban location in Narangam, also in a rural location. So we also did the same, followed the same model in Rangpur, Jolhara and Hatibanda. So the results from the rural location have been really positive. So in 1 year we have actually managed to have an impact on wasting prevalence. So from that angle, that has been very successful. In the urban, as I mentioned, there were challenges of actually keeping our temperature together. So what the government would like to do now is we are rolling out the rural model in more upazilas. And for urban, we are now probably going to maybe a couple more locations, but keep it still small because, as I mentioned, we feel that we still have more to before we scale up, and so we are now thinking of going back to the drawing board and rethinking what would be some of the issues for urban that would be different from rural, and we will probably work with Narendra and pick a few other urban locations. The World Bank is also moving in a large way to work with municipalities and other new city corporations all over the country with support with block grants so that to strengthen urban local governments, because a lot of these services have to be done at the local level with the help of other NGOs and private sector. So the model we have that we tested, that we are planning to now roll out, has a very strong element of including NGOs and other partners in the delivery, because for a conditional cash transfer project, if you do not have the supply side, the service delivery very well done, that's the crux, that's the main lifeline of the project. So that's the model.
Okay. We are at the end of the session. We know that already discussed, there are private sectors, there are governments, there are partnership programs in our country, but everything is for the benefit for our country people and for our country. So we also know that it is also discussed here. The peoples in the urban area, those poor people are coming in the urban area, they are staying in the slum area, and their health is very much irrespective of private sectors or government sectors or private government partnerships. Some private sectors are upcoming for profit, some are coming for only for services. So, and the audience who get time and for lively interaction for the sessions, and hope something will come out from this session and will be good for our nations. Thank you.